Thank you for your introduction. Thank Professor Pierpont's invitation, and I think we are old friends now. And thanks for Professor Xu Tianmin's inventing this wonderful technique. I'm Dr. Su Hong, and today I would like to share with you some of my experiences in treating crowding cases in teenagers. Okay, last September, I accepted the invitation. To give a lecture at Mahidol University. I was so happy to meet friends from Mahidol University, Chulalongkorn University, the Nation University, and University of PHYSIOLOGIC. Then I also accepted Professor Paibon's invitation to visit Chulalongkorn University Dental School. I like Thailand very much, and I hope to continue to communicate with you. Before we begin, anybody know who he is? Yeah, last year I showed this picture. Yes, this is a world champion in swimming, our Sun Yang. However, the photo gives an unconfident look. I always wonder, why was he so unhappy and unconfident? When he opened his mouth, we know the answers. The sharp teeth, yeah? They were so conspicuous that we even forgot he was a world champion. Then, some days later, boom! His photo became a breaking news. Look at this, not his muscle or the body. Please look at the teeth. Yeah, they were perfect lined and so beautiful. And he became a superstar. Many people seek orthodontic treatment for improving the appearance of their teeth or convex profile to get beautiful teeth and charming smile, like all those superstars. This scene, I believe everyone is familiar with. The summer counseling students' army. When the patient sits down, the first sentence is often the same. Doctor, my teeth are too crooked. It's almost everyone's chief complaint. On the other hand, crowded teeth are the most common orthodontic problem we need to address. In our daily work, we imply a series of orthodontic treatment to align the severely crowded teeth like this. We use appliance. We use the pads, we then close the spaces, and then thereby improving the oral function and aesthetics. The wildness and low self-esteem caused by the crowded teeth were greatly reduced after alignment, and the patient's smile were more elegant and quiet. So, orthodontics brings a new smile card, yeah? The word of crowding is not unfamiliar for Chinese people, and I believe it's the same for Thai people. Think about the past national holidays in our country. The mere mention of a word crowd can make everybody tense up and break out in a sweat, yeah? In the Great Wall. Yeah. About 20 years ago, I had once squeezed onto a green tree. It took over an hour to move into my seat after boarding. Seats are always limited, and when there are too many passengers, it becomes a scene like this picture. The standing ticket come into being. When there are more passengers and the two-dimensional space is no longer sufficient, tickets for three-dimensional suspending also appear. Yeah. And when the crowd is fully lined up in rows, marching in unison, it presents a different scene, order, harmony, aesthetics. People are so, the dozens of teeth we orthodontists faced every day are even more so. So solving crowding is the basic work we deal with every day. Very beautiful. There are many causes of dental crowding influenced by both genetic and environmental factors, such as insufficient jaw development, abnormal replacement of primary and permanent teeth, among others, which we will not elaborate on. In summary, it's a discrepancy of dental quantity and osseous volume, where the tooth size is relatively large and the bone size is relatively small, leading to insufficient arch width accommodate all the teeth on the dental arch. Crowding, especially common during adolescence, abnormalities in the replacement of primary and permanent teeth, as well as insufficient development of the jaw bones, can all contribute to this issue. In these cases, patients with crowded anterior teeth often have malaligned and protruding canines, which are commonly referred to as cute little tiger teeth. However, if not treated properly, they can frequently cause significant problems for orthodontic treatment. This picture is very classic. It's what we orthodontists want, to align crooked teeth according to our plan smoothly. This is also what we desire, for crowded teeth to be neatly retracted. But often, ideals are full, while reality is bony. It's quite possible that once you put on the appliance, the teeth won't align and just fly out. Or you might end up with a lawsuit, and during treatment, your patients end up like this. In our student days, we always heard people around us complaining to the teachers, how come the gap from the extracted teeth disappeared before the front is even moved? Just putting the appliance. And this situation tends to occur particularly among teenagers. Also, we have a subtle feeling that teenagers seem especially prone to lose anchorage. And this has been confirmed in our previous studies. In detail, different populations showed varying trends in anchorage loss under the same treatment, with adolescents experiencing more medial movement and tipping of molars than adults, suggesting that molar anchorage is not only related to the mechanic force of treatment, but also closely related to the individual characteristics of the patient. Let's see some cases. This 13-year-old boy has been undergoing treatment for about 3.5 months, whether with laceback or not. Okay. The premolars have already leaned forward to occupy the space here. Female, 12 years old, using SPEE-WIRE orthodontic technique, only started for 1 month. The mini screws were used to retract canines backward. At the early stage, the night-tie wire was soft and deformed, and the premolars and molars were also inclined forward. Why does using screws still result in loss of anchorage? When we were studying, we often worried about how to minimize the anchorage loss until I encountered this case, which is the very memorable adolescent case for me. This case, looking back, this was my first past case about 13 years ago, which gave me a first taste of the stunning treatment effect of past technique. A 12-year-old girl complaining of crooked tooth. Let's see. There's a severe crowding in the maxillary dentition. The canines are completely ectopic. The midline is deviated. There is slight overbite and a slight overjet. One lower incisor is missing, and there are multiple teeth with crossbite. It is designed to extract two maxillary four and one lower incisor. First time I did pass is completely follow the idea of SPEE-WIRE techniques. I didn't bond the left incisor at first, and after 1 month of follow-up, there was not much change. So I bound the upper two. Since I'm going abroad for a visit for over a month, considering the long time, I just boldly put all the 12 night-tie wire into the slots and tied them up with the 20 lecture. When I returned from abroad, I was surprised to find that in just a little over 1 month, almost all the teeth had been aligned, with very little space left. Not only made the severely crowded upper arch be efficiently aligned, but the molars stayed still. There was no tipping forward movement and early anchorage loss, which is very common in crowded cases, had been efficiently prevented. This is my first past case, and I was astonished. I felt like I just took my first step out and then was already on the verge of victory. The miraculous past system left me deeply impressed and interested, inspiring me to following Professor Xu in years of research and contemplation related to it. Sometimes I think the mouth is like a battlefield. The orthodontists are different from other specialists. We face about 20 teeth, and what we need to learn is macro design. And the most important thing in strategy is overall regulation, a comprehensive grasp, and tactics, designing the balance of power and countermeasures, simplifying the complexity. The global regulation I summarize as ensuring stability at the rear, clearing passage in the center, and rapid, accurate, and steady action at the front, quickly resolving the battle. And with the arrangement of nearly 30 teeth, it's not just a matter of placing a single arch wire or clear liner. Otherwise, the team would be in chaos. Like the battlefield, we still need to stabilize the position of the molars, control the front teeth well to achieve the ideal direction to alleviate crowding or protrusion, while ensuring the movement between the front and back teeth is efficient and smoothly. For the sake of better therapeutic effects, these 3 points are indispensable, I think. And if different technologies want to make breakthroughs, they must be focused on these 3 aspects. Moreover, it is not just the treatment of malocclusions in 3-dimensional space that we should focus on, but also the concept of 4-dimensional orthodontics that takes into account the growth and development of the dentofacial complex. Similarly, for edentulous jaws, those of infants and the elderly are completely different. One is brimming with vibrant vitality, while the other is in a state of gradual decline. Malocclusions in adolescents differ from those in adults not only in psychological characteristics, but also in the arrangement of the same 28 teeth, which can vary significantly. Let's first take a look at the position of the important anchor molars. Our previous large sample studies have found that regardless of the type of malocclusion, the upper 6 of adolescents is more distal tipping in the natural state, with a highly significant difference from that of the adults. The younger the age, the more obvious it is, and this state is closely related to orthodontic anchor control. Currently, the most commonly used orthodontic treatment is the SPEE-WIRE appliance. On one hand, the important reference data for the orthodontic appliance is based on the 6 gaze to normal occlusion, measured from the adult normal occlusion. On the other hand, the requirement for the arch wire to flatten the original SPEE-WIRE has also become a standardized process that must be carried out in the SPEE-WIRE technique. As previously mentioned, the natural inclination of the posterior teeth in adolescents is mesial tipping, indicating a deeper, as distal tipping, indication a deeper SPEE curve and greater anchorage reserve. Our research also showed that in adolescents, the posterior teeth are most proclined and mesial moved during SPEE-WIRE treatment, resulting in anchorage loss, which is detrimental to the treatment. As shown in the diagram, the significant changes in the SPEE curve of many adolescent patients occurred before and after treatment. This leads us to wonder whether it is necessary to standardize the leveling of the SPEE curve for them based on the adult data. We all know that mammals naturally have a physiologic curve of SPEE. And the backward inclination of the molar teeth themselves is part of the natural sagittal occlusal curve in the molar region. And the curvature is particularly pronounced during adolescence. In adolescence, especially in class 2 patients and patients with high angles, the curvature is particularly pronounced. Then we extract 4, leveling the SPEE curve with arch wire as a goal not to affect function and stability, but may also lead to the loss of iatrogenic anchorage loss, increasing the difficulty of treatment. Additionally, adolescent patients themselves show a significant difference from adults. The upper six is more backward inclined at first. If we abounding conventional tubes and brackets at the beginning of treatment, when the night-eye wire is inserted, the arch wire deforms and the fine wire directly applies a significant forward rotating torque. Then, due to the extraction space and the proximity of tooth 6, tipping will occur quickly. It is only at the initial stage of treatment, the night-eye wire stage. We haven't even started closing the space with SS wires yet, and the tipping will cause anchorage loss. At this stage, there's nothing else to do but place an orthodontic minuscule here, here, and here to strive for the remaining space, like mending the fold after the shape has been lost. Or distalizing molars. Wouldn't this back and forth movement consume a lot of time? We often need anchorage, not because we don't have enough space. Most of the time, we do. 7 to 8 millimeters is often enough. We don't have enough space, always because we lose too much. On the other hand, in the anterior segment, for cases with precise control requirements in the anterior region, when the upper four are extracted in SPEE-WIRE orthodontics, after the initial night-eye wire is engaged, the canine are subjected to a mutual downward tipping. A mutual downward tipping moment that moves them forward and downward. However, due to difficulty of movement caused by crowding, the adjacent tooths are directly opposes the high and malpositioned upper canine is the upper 5. It directly tipped forward and moved upward to occupy the extraction space, resulting in loss of anchorage and a forced change in functional occlusal plane. Then, strict anchorage control measures are not adopted for the posterior teeth. The upper 6 is affected by 5 and will tip forward during the night-eye wire in the lining stage. In adolescent patient, the upper 6 are naturally more distally inclined. Under the tipping moment of the night-eye wire, they are more significantly affected and tend to tip forward, losing anchorage. So, I think from the results, we found that in the early stage of treating adolescent crowding, the SPEE-WIRE is particularly prone to lose anchorage. Let's analyze the corresponding reasons, such as the relative distal inclination of molars, the relative high position of canines, the preset mesial angulation of the SPEE-WIRE buccal tubes, and the use of straight night-eye arch wires, all of which generate a bad force system for the anchor teeth, leading to early anchorage loss. This is the deep pit we often fall into when treating adolescent crowding cases with the SPEE-WIRE system, which I call the trap of crowding. Therefore, when orthodontists exhaust all means in front of patients, we tried many things, many measures. We found that we are only lone warriors who move ourselves. The mechanics of the appliance and the arch wires leave you exhausted. So the anchorage is lost. The space is gone. And the front teeth are not aligned. When the anchorage is gone, we have to cross over 10,000 mountains to find it. How can we prevent such anchorage loss? Here comes the PASS system, the physiological anchorage SPEE-WIRE system. Remember my first PASS case? A case of severe crowding in a teenager that was easily resolved without losing anchorage over 2 months. Using PASS treatment has significant advantages. PASS has 2 main components, the XPD buccal tube and the multi-level low friction brackets. Starting from the first night-high wire, we can see the minus 25-degree tip-back tube can prevent initial tipping of the teeth due to night-high wire, and the 3/6 torque system allows for a rapid retraction of the canines. The minus 7-degree main tube can maintain the original distal tipping anchorage reserve of posterior teeth to counteract the loss of molar anchorage during the space closure stage. And the MLF brackets, we can independently control the optimal values of friction and corrective forces, allow teeth to drift freely in a controlled manner. Starting from the first night-high wire, PASS has incorporated precise control, low friction, and reduction of tooth reciprocating motion, and efficient progress throughout various aspects. How does PASS avoid pitfalls and achieve high efficiency? Do you still remember the 3 major aspects of overall regulation? Okay, let's see. Still regarding the molar position mentioned earlier, then we put the XPT on. The posterior tilt auxiliary tube of PASS prevents the anterior inclination of the upper 6 by controlling the inclination. The unique design enables the upper 6 to no longer be affected by the anterior inclination moment in the initial stage, maintaining the original posterior inclination anchorage reserve state, thereby effectively preventing the loss of anchorage in the initial stage, and using arch wire with a curve of SPEE to space closure in the later stage, and more space have been preserved. Therefore, allowing some forward movement of the molars still achieves a strong anchorage effect. By preventing issues before they occur, it is possible to maximize anchorage while minimizing anchorage loss. Compared to traditional straight wire appliances, PASS aims to maintain the SPEE curve in the posterior segment. This concept is very important. The PASS system redefines the target position of posterior teeth. The settling and maintenance of the target molar position is the key to orthodontics. And it's applicable to all appliances. This concept can be applied to a wide range of appliances, including the Invisalign techniques. The Invisalign G6 enhanced version has been referred to the molar backward tilt into the design. and an advantage too. Let's look at the position of anterior teeth, the canine. What is its status? It's a key inflection point of the dental arch, the canine. Solving the problem of canine early is crucial to unlocking the key pathway for sliding between the anterior and posterior teeth. The unique buccal tube design of the PASS system, which is tilted backward, causes the wire to be in the most malaligned state at the first molar, taking on the dominant moment, creating a unique 3-6 moment system. This resulted in both the mal-positioned canines and molars being subjected to a backward tilting moment, causing the canines to drift back quickly on their own, reducing the back and forth movements and leading to efficient alignment of the anterior segment, solving crowding and the key to retracting the protruding teeth. This is a significant advantage of physiologic anchorage system. Finally, let's take a look at the slide structure of the conventional brackets. With the same slot and robust bracket wings, Professor Xu has made a very ingenious change here by removing a bit of the steel under the bracket wings. This reduction opens up countless possibilities. You can see that after conventional ligation, the lecture wire hides in this area, and the removal of this material allows the lecture wire to slide to the top during the ligation, simulating the effect of the self-ligating brackets. We can see the picture here, just like a self-ligating bracket. The conventional self-ligating brackets, although they increase the clearance, which greatly reduces the friction force of the arch wire, at the same time, they also cause insufficient arch wire deformation, resulting in relatively weakened orthodontic forces and reduced control over teeth, and thus need to be supplemental by other methods. However, PASS brackets enable us to have many control methods for the clearance. The ligation method is very flexible. We can have the lecture in the afternoon. We can use the 12, the 14, the 16, the 18 arch wire, and we can use 20, 25, and 30 lecture. We can choose to combine different lecture wires while using different working arch wires to freely reduce friction or increase orthodontic force. As shown in the diagram, we can use different lecture in different places, completing many tasks in one follow-up. We have various ligation methods to adjust bracket distance. The system friction is adjustable, and the approach is very flexible, and it can effectively control system friction and corrective forces. So, in summary, stabilizing the posterior teeth targets extremely easy movement and control of anterior teeth, combined different with efficient sliding arch wires between the anterior and posterior teeth, make up a highly efficient PASS operating system. In each stage of treatment, PASS demonstrates its efficiency advantage. First of all, after the initial ligation with a 20 lecture wire, it has a similar self-ligating effect, where the fine nitrile wire is not affected by the friction of ligation. So it's very rapid lining. Typical characteristics at this stage, there's a significant posterior drifting of the front teeth. We can see here. You can see the space. And using buccal tubes with ceramic brackets, which have not so low friction is also showed the space here. It's the 6-3 moment makes the canine move backward. During the bite opening stage, a thin stainless steel auxiliary arch can be used. This stage is the unique dual wire system of pass, which can align and open the bite simultaneously. After lining and opening bite, we bound 5 and 7. At this stage, all arch wire has a SPEE curve, maintaining anchorage reserve, preparing for space closure. And in the final stage of space closure, the design of double slot grooves for anterior and posterior teeth enables precise and efficient control of anterior teeth and rapid and low friction retraction of posterior teeth. The dental arch are gradually tilt backward while maintaining occlusion. This overall high efficiency of pass system allows for rapid alignment of the dental arch, space closure, and occlusal adjustment. Enable most cases of extraction for crowding to be completed in just over 1 year, or even within 1 year. Let's see some cases. After the last one, let's see this boy. I was still not satisfied, so for this child, I used the pass appliance to him. You can see. Okay. Okay. You can see the boy. Both the upper and lower dentitions are severely crowded. How should the kind of case be studied? This is the buccal tube plane of the first molar. And the canine is much higher than this plane. The white line represents the posterior occlusal plane, and the black line represents the canine molar occlusal plane. Once the nitrile wire is directly inserted into the canine, following the conventional straight wire arch treatment, regardless of the methods we use, whether it is laid back or using a mini screw to pull the canine backward. As long as the nitrile wire is inserted in the slot, the 5 and 6 will immediately be elevated and tilt forward, occupying the space and losing anchorage. As for the anterior teeth, they will be aligned by tilting forward, and the occlusal plane will be changed. And the consequence will be disastrous. So I used the pass. After 3 months, the upper jaw has been wearing an orthodontic appliance for 3 months, and the nitrile wire has been inserted into the tip-back tube. The severe crowding has been largely relieved, and the space has been well utilized. And the posterior teeth has not moved forward, and the lower jaw has been weared in the orthodontic appliance for 2 months. And the nitrile arch wire has been inserted into the tip-back slot. The severe crowding has been basically resolved in just 3 months. And the posterior teeth have not moved forward. We can see this is maxillary occlusal plane before and during treatment. And this is the scanned model. After 3 months of treatment, the upper jaw is basically aligned. The space is completely used by the anterior teeth, and the molar stayed still. In the lower, after 2 months of treatment, the lower arch is basically aligned. The space is completely used by anterior teeth. From the right side view, the upper right canine has changed from the anterior inclination to an upright position by nearly 20 degrees and has moved backward by nearly 9 millimeters. And the severe crowding of anterior teeth has been quickly relieved. And the molar stayed still. From the left view, the upper 6 has posteriorly inclined nearly 4 degrees. Nearly 4 degrees and has moved backward. And the upper canine has moved backward by nearly 6.5 millimeters. And the severe crowding has been quickly aligned. So, just 3 months, we use pads to align so severely aligned teeth. For such cases, I think if we use the straight arch wire techniques, the treatment to alleviate crowding, typically, it will take about 1 year. So we save the time. We save the time for the patient and for us. Just use pads just in 3 months. It's magic technique. Another case, let's see it quickly. This is a crooked teeth girl. The intraoral view, severe crowding case. So we extracted the 4 fours. 3 months, we aligned the anterior teeth, and we can see the space here. We use no lace back or tags. The space appears, and we bound 5 and 7, align the teeth, close space, and occlusal just. After treatment, occlusion is harmonious. The dentitions well aligned, and the cusp-fossa relationship is very good. And we can see the curve of SPEE, normal curve of SPEE. The smile is changed a lot. You can see a beautiful girl. The pre and post comparison. You can see the occlusal status before and after treatment. Looks very well. We can see a curve of SPEE. In the left side, we can see the curve of SPEE, same as the right side. Comparison of several measures before and after treatment. As you can see, the anchorage has been well controlled. Let's look at a non-extraction boy, a crossbite boy. You can see the malar minus. The maxillary development is not satisfactory, and the upper lip is retreated, and the lower lip is protruded. Normal angle. You can see a pre-treatment view. Anterior crossbite, I don't have enough time. Okay, but it's a boy, so we choose a non-extraction and compensatory treatment, resolving overbite and overjet, and we do the oral hygiene education. 1 month after rebonding. When we didn't extract the teeth, we put the night-eye wire into the main tube of the buccal tube, and we elevate the posterior teeth. After bonding in 3 months, the anterior teeth achieved occlusal contact. Then we change the arch wires, and we use lower 18 SS round arch wire to close the space and resolve the anterior crossbite. 3 months, the anterior crossbite has been resolved, and the elevating material has been gradually worn down. I just in the process of slowly adjusting and educating on the brushing teeth and waiting for the second molar to erupt. 5 months later, like this, and the upper 7 teeth finally erupted in a good position, and the oral hygiene improves as well. Then, near 1 year, we finished the treatment. We can see a neutral molar and canine relationship, and a good overbite, overjet, good midline, good occlusion. And it should be noted that the maxillary 6, we can see a natural, a physiologic curve of SPEE. And I think the curve of SPEE, if we control the molar, controlling the forward inclination of the molars have great benefits for the improvement of bone development and congestion. And maintaining the physiologic curve of SPEE of posterior teeth has a very good impact on the occlusal function. Okay, after treatment, the upper lip protrusion improved significantly, and temperament changed, and the smile was very beautiful here. The lateral appearance changed well, and the upper lip came out. The front showed very handsome. Yeah. The comparison of the facial profile, elegant facial figures, improved profile. Okay, we can see the class 1 relationship, just 1 year, no extraction, use pass technique. The pre and post treatment comparison of hard tissues. On X-ray, which showed obvious skeletal and dental improvement, and it was more intuitive when combined with the comparison of soft tissues. The result of cephalometric superimposition. Okay. Let's summarize the advantage of the PASS system. Do you remember the unfavorable force systems of common orthodontic treatment that lead to early anchorage loss? We will address each issue one by one. If the molar is relatively posteriorly inclined, we can use the PASS system to maintain the the anchorage resolve. We can maintain the molar anchorage. If the canines are relatively high, we can use the light force and large posterior inclination moment generated by the night-eye wire, and to make them quickly and automatically drift backward. Here, we make the canine drift distally. What about the preset anterior inclination angle of the buccal tube? We can adjust the data of the buccal tube and use the posterior inclination tube during the alignment, making the molars the dominant moment. As for the straight arch wire entering the slot, it's soft. When it enters the posterior inclination tube, both 3 and 6 have posterior inclination moments, killing 2 birds with 1 stone. Therefore, the PASS system perfectly avoids the crowding trap in the early alignment state using the SPEE-WIRE system, so can prevent early anchorage loss. And we can see the low friction mechanical of the PASS system reduces the friction during canine posterior movement, and the life force for posterior movement reduces the load on the anchor molars, saves more space, and makes the treatment extremely efficient, simple, and most crowding can be effectively improved within 3 months. So, back to the main topic. I have been engaged in orthodontics for more than 10 years, and my sentiment has never changed. That is, for adolescent crowding, PASS is the first choice. Yeah. The long season will eventually fade away. Let's pick up the PASS system and snap our fingers, allow the teeth, the lost teeth, to speed along easily on their way home. Okay, thank you very much. May PASS be with you. Wish everybody study PASS like my little baby. Thank you. Thank you. Oh, a question. 12点了，或者我们就下课。Or let's go to lunch.
Hello. So if anyone has any questions, I'll be passing the mic around.
Okay, let's go to lunch.
Okay, so if anyone has any questions, in the afternoon we have a question and answer session, so you could keep your questions to ask during that session. So right now, I think, thank you, Dr. Su, for such a informative lecture, and I think we'll be going into lunch. Okay, thank you so much.